Assalamualaikum doctors. In this video I am discussing the discussion portion of SLE history management. First of all, how I will manage this case. So this is a case of systemic lupus erythematosus. So I will assess the patient carefully. I will assess the ABC, vitals, blood pressure and blood glucose. I will examine the patient generally for signs of any steroid toxicity. I will do a full musculoskeletal examination with a full range of movements, full cardiac, chest and abdominal examinations. Involve my senior and involve the team. Okay, so again I will assess the patient carefully. I will assess the ABC, vitals, blood pressure and blood glucose. I will examine the patient generally for signs of any steroid toxicity. I will do a full musculoskeletal examination with a full range of movements, full cardiac, chest and abdominal examinations. I involve senior, involve the team. Now what investigation do? For diagnosis by 4 out of 11 of this diagnostic criteria with one immunological or biopsy proven lupus nephritis with positive ANA and anti-DNA. So diagnosis 4 out of 11, remember the diagnostic criteria, and with one immunological or biopsy proven lupus nephritis and positive ANA and anti-DNA. So SLE criteria easy to remember, that is SOAP, brain MD, that is SOAP, S for serositis, pruritus and pericarditis, O for oral ulcer, A for arthritis, P for photosensitivity, B for blood disorders, R for renal involvement, A for ANA positive, N for neurologic like immunologic, anti-Smith antibody, anti-double standard DNA antibody, M for malar rash and D for discoid rash. So serositis, pruritus, pericarditis, oral ulcer, arthritis, photosensitivity, blood disorders, renal involvement, ANA positive, immunological involvement, that is anti-Smith, anti-double standard DNA antibody, N for neurological, M for molar rash and discoid rash. So N for neurologic, that is psychosis develop. Remember, that is SLE classifications criteria for the systemic lupus erythematosus. Requirement more than or equal 4 criteria, at least 1 clinical and 1 laboratory criteria, or biopsy proven lupus nephritis with positive ANA or anti-DNA. Clinical criteria: number 1 acute cutaneous lupus, number 2 chronic cutaneous lupus, number 3 oral or nasal ulcer, number 4 non-scarring alopecia, 5 is arthritis, 6 serositis, 7 renal, 8 neurologic, 9 hemolytic anemia, 10 leukopenia and 11 is thrombocytopenia less than 1 lakh. And immunological criteria are positive ANA, anti-DNA, anti-Smith, anti-phospholipid antibody, low complement, that is C3, C4, CH50, and direct comp tests do not count in the presence of hemolytic anemia. Now some investigation, what are we are doing? Bedside we are doing blood pressure, random blood glucose and urine dipstick. The lab full blood count, either normocytic normochromic anemia of chronic disease or pancytopenia with leukopenia and a thrombocytopenia or autoimmunohemolytic anemia. Inflammatory marker or ESR is very high with normal CRP, coagulation profile, urinalysis, liver function test and kidney function test. ANA if positive, proceed to INA panel. Then INA panel is that antibodies against the extractable nuclear antigens, autoantibodies. Anti-double standard DNA highly specific may reflect the disease activity, especially nephropathy. Anti-Smith antibody, anti-RO and anti-LA antibody, that is positive in 30%. Anti-RO antibody SLE plus Jogren disease. Anti-LA antibody in neonatal lupus. Anti-phospholipid antibody positive in 30% and increased risk of thrombosis. Anti-histone antibody increase in drug-induced lupus. Anti-RNA antibody associated with Raynaud phenomena, and if high, it is associated with mixed CT disease, not SLE only. Anti-RNP is associated with mixed connective tissue disease. Neonatal lupus is almost always caused by anti-RO and anti-LA antibody. Remember, neonatal lupus is almost caused by anti-RO and anti-LA antibody. Complement C3, C4, there is hypocomplementemia. Raised complement is against the diagnosis of SLE. Remember hypocomplementemia. Imaging or chest X-ray, echo and cranial MRI depends on clinical sign. Finding abdominal ultrasound for hepatosplenomegaly, joint ultrasound or even joint aspiration if needed after liaison with the interventional radiologist and slit lamp for uveitis. So I am telling what we are doing. Bedside we are doing the blood pressure, random blood glucose and urine dipstick. Then lab full blood count we are doing inflammatory marker ESR, CRP, okay, coagulation profile, urinalysis, liver function and kidney function test, and we are doing ANA study, all the antibody ENA panel under. Then complement lead C3, C4 is low. For slit lamp examination, for eye examination uveitis, and imagine chest X-ray, echo, cranial MRI. Some advice we give the SLE patient: number 1, diet and exercise. Avoid high calorie, high salt food or to avoid steroid induced weight gain, and encourage exercise. So diet and exercise they will take. Number 2, sun protection, wear sunscreen, SP50 daily on all exposed skin. Avoid nephrotoxic drug. Education of the family regarding the side effect of medications. Report any chest pain. Seek medical advice immediately. Fatigue and sleep. Fatigue is common and affect the school performance, and steroids may induce the sleep disturbance, so lies with the school. Psychosocial issue. Education of the child and family about the SLE is essential. Poor school attendance may indicate psychosocial issue. Immunization. Live vaccines are contraindicated in those on corticosteroid immunosuppressions, but pneumococcal vaccine at diagnosis and 5-yearly and influenza vaccine yearly is recommended. Avoid infection overcrowded places, street food, travel to endemic areas, and steroid card and bracelet. So what are the advice we are giving? Avoid high calorie diet and exercise regularly. Avoid the sun exposure or protection against sun exposure. Avoid nephrotoxic drug. Avoid infection. About the family education about the disease process and the side effects of medications. Fatigue and sleep is the common effect. Psychosocial issue. Immunization. Live vaccines are contraindicated who are taking corticosteroid. These are steroid card and bracelet should be used. Okay. Now about the main treatment. Management is non-medical and medical treatment. Non-medical are RICE like rest, ice, compression, inhalation. Rest, ice, compression, inhalation. Medical treatment analgesic NSAID for musculoskeletal symptoms and serositis with precautions regarding nephritis. Hydroxychloroquine first line treatment for mild disease, skin, joint, pulmonary disease or as adjunctive treatment in more severe disease. Annual monitoring visual field color vision is done. Corticosteroids are nearly always required at some stage. In severe systemic disease, IV methylprednisolone for 3 days is given initially, followed by oral prednisolone, which is subsequently tapered. Immunosuppressive agent azathioprine or MMF is used for moderate to severe disease, and cyclophosphamide for severe organ involvement. Anti-TNF, infliximab and etanercept not used in SLE as it can induce low pulse activity. For severe disease resistant to standard therapy. Biological therapy, rituximab, plasmapheresis, splenectomy, autologous or allogenic bone marrow or stem cell transplant. So these are the treatment. First of all, non-radical RICE and medical we are treated NSAID, we give hydroxychloroquine. Remember, NSAID first line treatment for mild disease, hydroxychloroquine, NSAID, hydroxychloroquine, corticosteroid, immunosuppressive. Then for severe cases we are given biological therapy, rituximab. So I am again telling treatment. First of all, non-medical are RICE, rest, elevation, compressions, and rest, ice. And the medical treatment are these are first of all we are giving NSAID, hydroxychloroquine, then corticosteroid, biological agents, anti-TNF, immunosuppressive agent. Team we are involving are consulted pediatrics, rheumatologists, ophthalmologists, nephrologists, cardiologists, physiotherapists, psychologists, psychiatrists, occupational therapist, social orthotist, hand and foot specialist, and lies with the school. So teams are my consultant pediatrician, rheumatologist, ophthalmologist, nephrologist, cardiologist, physiotherapist, psychologist, psychiatrist, occupational therapist, social orthotist, hand and foot specialist, and lies with the school. External infection is an important cause of mortality. Cause of chest pain in SLE are pleurisy, pericarditis, pulmonary embolism. Drug-induced lupus is isoniazid, minocycline, anticonvulsant, infliximab, terbinafine, procainamide, hydralazine, and quinidine. What are the DD of arthritis? DD of arthritis, monoarthritis, I am telling, trauma, NAI, infection like septic and post-streptococcal, inflammation are transient and reactive, blood disorder, sickle cell disease, hemophilia, and Parthis Sufi. Polyarth, psoriasis, enthesitis, related arthritis, synovitis, reactive, Kawasaki, PIMS, Hanascolin purpura, parvovirus, and rheumatic fever. Chronic are mono and poly. Mono are oligoarticular GIA, psoriasis, ERA, synovitis, and malignancy. Poly are GIA, SLE, diabetes mellitus, psoriasis, EDA, IBD, tuberculosis, Lyme, and malignancy. Complex regional pain syndrome. So this is all about SLE history. Thank you.